All right. So hi, everybody, and welcome today to our panel discussion on the Best of ASCO 2024, What Patients Need to Know. I'm joined today by a few members of our editorial board and fellows forum, Dr. Sam Kareff, Dr. Matt Hadfield, and Dr. Morana Vojnic. They have a really thoughtful discussion planned for today covering some of the most significant research updates that were presented at the ASCO annual meeting that took place earlier this month. If anybody has any questions throughout the talk, feel free to type them into the chat, and our panelists will have some time at the end to answer everybody's questions. So with that, I will turn it over to Dr. Hadfield to begin the introductions and start the conversation.
Great. Thanks so much, Kara. And welcome everyone to what I think will be a very interesting and spirited conversation after a very jam-packed ASCO as it typically is. I'm Matt Hadfield. I'm just wrapping up my third year of medical oncology fellowship at Brown University in Providence, Rhode Island, and will be joining the faculty there in the coming weeks, focusing on early drug development and cutaneous malignancies, and looking forward to this conversation. And with that, I will pass it over to Dr. Vojnic to introduce herself.
Hi, I'm Dr. Morana Vojnic. I'm from Lenox Hill, Northwell Health here in New York City, Manhattan. I'm a medical oncologist who focuses on neuro-oncology and thoracic oncology. Nice to be here with all of you today.
And Dr. Kareff.
Thank you, Drs. Hadfield and Vojnic. My name is Dr. Samuel Kareff. I'm the outgoing Chief Fellow at the University of Miami Sylvester Comprehensive Cancer Center. I'll be entering hybrid practice shortly with a focus on thoracic and gastrointestinal malignancies.
And then I'll let Dr. Seetharamu introduce herself as well.
Hi, everyone. So happy to be with you all. I am a thoracic and head and neck oncologist, also at Northwell Health. And I'll be talking about the head and neck highlights from ASCO.
Great. So I know we have an awful lot to talk about today. As we mentioned before the conversation started, there was so much that happened at ASCO this year. So I think Sam, Morana, maybe both of you can kick us off with giving us maybe the highlights in the thoracic world and what everyone should really know moving forward from a patient perspective.
Absolutely. I'm happy to kick us off today. I'm hoping just to take 1 minute to discuss 3 of the abstracts that were presented at the ASCO plenary session, and this was colloquially referred to as ASCO Lung on social media due to the plethora of findings in thoracic oncology. So I'll kick us off with abstract number 3, which was the REACH-PC trial. What this trial looked at was early palliative care referral, as we had already known, has shown increased survival and quality of life in patients with advanced lung cancer. But what was unknown prior to this trial was if the use of telemedicine to conduct palliative care was equivalent in terms of outcomes for patients with lung cancer. So in this trial, patients were randomized 1-to-1 to receive palliative care via a virtual or an in-person visit format, noting that all patients were to receive the first visit in person in boosts of rapport between the palliative care provider and the patient. And the goal of the trial was patient-reported outcomes, meaning if patients felt that their quality of life was improved with either of these formats. And bear with me for the double negative here, but the patient-reported outcomes were non-inferior in the virtual compared to the in-person arm, meaning that both arms performed equally well for patients who received palliative care either through a virtual or an in-person format. Another notable finding was that caregiver attendance associated with these visits was higher in person versus with virtual visits. So the conclusions from this trial were that a stepped-up approach to virtual versus in-person palliative care were equivalent in terms of the patient-reported outcomes. And what's most exciting about this trial is that likely policy and reimbursement changes will result given the equivalence shown in both arms.
Yeah, Sam, just to stop you right there, because that was such a huge topic of discussion at ASCO this year, and so many people. I mean, it was interesting and great to see that palliative care focused abstract made it so high at the biggest. I think that's probably the first time ever that there was a palliative care focused plenary session in recent memory. What do you think the implications are on both patient care as well as rationale for reimbursements from a insurance claims perspective?
Thank you. And like you alluded to, I do think this is very monumental in terms of its importance at the ASCO plenary session. So I think 2 take-home points are very important from this plenary session. The first, as you mentioned, Policy and reimbursement changes will likely result from this. This is super important because we know that there's a shortage of palliative care providers in the United States, at least. And if we can democratize access to this, meaning free up time in clinic or decrease financial toxicity and time toxicity burden for patients, this will be very helpful. The second very important ramification of this is that patient-reported outcomes are very important data, and the field is appropriately catching on to making sure that these findings are vocalized at the national and international levels. And it was really a pleasure to see this reported at the plenary.
And I feel like they're adding patient-reported outcomes now to the majority of clinical trials as well, which is like extremely important, as Dr. Kareff just said. And so this plenary session where palliative care was in the plenary session was quite remarkable. So we already have the guidelines in lung cancer to refer patients to palliative care early on, but having this opportunity, having this data saying that video and telehealth, which is extremely important to have access to that. Nobody wants to travel multiple times, right? It's amazing. Yeah.
Yeah, no, it was really wonderful to see. And I know in my own clinic, I've had many experiences where I wanted to have patients be seen by palliative care and they just couldn't coordinate appointments on days when they're getting treatment. And they decided not to see palliative. For that reason, they didn't want to come in for more appointments. So, I mean, something like this is huge for the whole community. So really great to see.
Absolutely. Couldn't agree more. Moving on, the second plenary session that was focused on thoracic oncology was the LAURA study. So in this study, we're talking about a specific type of lung cancer called non-small cell lung cancer. Specifically within that subset, we're referring to patients who have a mutation in a gene called EGFR. And what this study looked at was for patients with what we call locally advanced, meaning where surgery is likely not an option for these patients. When they were randomized to receive standard of care chemoradiation, followed by maintenance osimertinib, which is a targeted therapy directed towards the EGFR gene, versus placebo, meaning no maintenance therapy given, was there an improvement in a survival outcome, specifically progression-free survival, meaning living without progression of the lung cancer disease? Other endpoints that were looked at in this trial were overall survival, meaning total lifespan, and safety outcomes. Now, one note I want to make about this trial before we get into the results is that patients who received osimertinib in the experimental arm were done so indefinitely, meaning that there was no end date for this drug. And in terms of the results, they did find that osimertinib maintenance therapy resulted in prolonged progression-free survival. I want to highlight the months because it's very impressive. 39.1 months versus 5.6 months compared to the placebo. And there was indeed interim overall survival data presented as well, which showed an improvement in 3-year survival of 84 versus 74%. So this trial was very important because it confirmed that using targeted therapy, in this case, osimertinib for EGFR mutant non-small cell lung cancer after definitive chemoradiation therapy resulted in improved survival outcomes for this patient population. This trial was one of 2 during the plenary session that received a standing ovation.
No, absolutely remarkable work with the EGFR targeted therapy now trickling down into the adjuvant, neoadjuvant setting. I want to ask just a couple questions. Sam, do you think this is something that people in Sam and Morana, is this something that thoracic oncologists have already been doing, and this is just confirming what everyone's already been doing, or is this actually practice changing, and that this is a new standard of care that will be adopted, around the country and the world?
Great question, Dr. Hadfield. Yes, I have seen the off-label use of osimertinib in this disease setting, noting that the trial results had not been formally reported until this time. Now, naturally, as a result of these trial results, you can imagine that the drug manufacturer is applying quickly to the FDA for accelerated or full approvals in this disease setting, and I would be shocked if a trial as positive as this did not result in such approval.
And in the EGFR metastatic setting, as Dr. Kareff said, a lot of thoracic oncologists have been using off-label adjuvant osimertinib or Tagrisso instead of just placebo or the durvalumab, so the immunotherapy, which is standard used in this setting, just because of the way these patients with EGFR mutant lung cancer, the way the disease grows, the way the disease is formed, we know that targeted therapy is typically the way to go. So just having these results that provided a standing ovation at ASCO is, again, another remarkable feat.
Yeah, it was a good year for plenaries. And I think it's and melanoma is the last plenary we're going to talk about, so it's really good. One of the other things I think is just good to highlight right here is the fact that EGFR testing is so important in thoracic oncology patients, and it may seem trivial to mention this for those of us that work in academics, but there's still data to suggest that a significant amount of patients around the United States and the world are not getting whole exome sequencing or targeted therapy panels at time of diagnosis, and it's absolutely critical if you're a patient diagnosed with lung cancer that you speak to your oncologist about this and make sure that that's something that's happening, because it really does have significant implications for how you're treated and managed. And Dr. Vojnic, do you want to talk to us about what else was interesting in thoracic oncology?
Well, we had another plenary session. I don't know, Dr. Kareff, if you want to mention the other plenary session for our small cell lung cancer.
Sure, I'll round us out very quickly, Dr. Vojnic. So the third and final thoracic oncology focused plenary session that was presented this year was the Adriatic study. And in this time, we're talking about small cell lung cancer, specifically in the limited stage. We know that the standard of care for patients with this subtype of small cell lung cancer includes chemoradiation therapy, maybe with prophylactic cranial irradiation. We can discuss this at another time, but unfortunately, we know that disease outcomes remain poor in this patient population. So in this trial, there was actually a 1-to-1-to-1 randomization of patients with this disease to maintenance durvalumab after the chemoradiation portion, maintenance durvalumab with tremelimumab, although these data have not yet been presented or reported, or placebo for 24 months duration. The primary endpoints were outcomes data, again, progression-free and overall survival, similar to the trial we just discussed. There were additional secondary endpoints looking at things like safety as well. And yet again, we have another positive trial for patients where we saw that those who received maintenance durvalumab therapy after definitive chemoradiation lived longer, specifically in terms of overall survival, 55.9 versus 33.4 months, and for progression-free survival, 16.6 versus 9.2 months. I want to note one safety signal that was noted in this trial, which was a disease entity called radiation pneumonitis, or basically inflammation of the lung tissue. This is something we have seen with the combination or the close use of radiation therapy with immunotherapies like durvalumab. And indeed, there were a few patients on this trial who had this complication. Really excitingly, and again, receiving yet another standing ovation, we see that consolidative durvalumab will likely become the new standard of care for this patient population. And this is so important because we know of the grim outcomes for patients who have refractory small cell lung cancer. And this wraps up the 3 plenary sessions related to thoracic oncology this year at ASCO.
No, yeah, absolutely. Remarkable results in a disease state that's very, very hard to treat. And obviously, I know we all know in the metastatic setting that, even chemo IO does not provide that much better of a survival benefit. And you're really hoping for that tail of the curve effect. Same question as before. You think this is something that everyone's going to adopt right away? Because I have heard some criticisms about the Adriatic trial that, immunotherapy toxicities were maybe underappreciated or underreported, and there's this concern that I think in general in the oncology community there's more and more concern about using immune therapies in the neoadjuvant adjuvant setting. What are all of your thoughts on that?
Yes, I couldn't agree more. It's a legitimate concern, and the trial data backs us up. But like you said, we have had experience in other disease states and other disease types, even with the combination of the two. So ensuring that we're monitoring very closely for these complications should lead to the maximum safety benefit for these patients. I think with results like these, especially in a disease like small cell lung cancer, I'd find it hard to believe that the manufacturer wouldn't go for accelerated or full approval swiftly.
And we use the same, basically similar type of regimen in the post-chemo RT setting in the non-small cell lung cancer world. So we have data from that spectrum of the disease. So yeah, agreed.
Awesome. Well, thank you very much. So what else can we get excited about in terms of thoracic oncology, or maybe pessimistic about? I don't know, depending on what you'll tell us.
Well, there were a lot of different trials presented. I think some of the most notable ones, which I got excited about, was, for example, Paloma 3, the phase 3 study, which actually looked at the new preparation. So Paloma 3 was a trial where they looked at EGFR mutant non-small cell lung cancer in the recurrent setting, and they looked at subcutaneous administration of a drug called amivantamab instead of IV. So this regimen, amivantamab plus lazertinib, is actually already approved in the EGFR mutant lung cancer sphere for the recurrent patients, metastatic. However, the IV amivantamab does carry significant risk of infusion reactions, so they created this new preparation, which is subcutaneous. And the trial results were very positive. So the overall response rate was 30% for the subcutaneous administration in compared to the IV. And the duration of response was actually slightly bigger, 11.2 months versus 8.3 months. So I am quite hopeful, and I hope you guys too are, that we're going to have a new preparation that's going to be available for these patients, especially when the IV preparation does carry a significant risk of side effects.
I think it's a great point. I mean, as we start developing more subcutaneous immune checkpoint inhibitors too, I think it's going to really reduce burden on, in addition to better toxicity profile, it's going to reduce burden on infusion staff and patient and time toxicity, as well as time toxicity or financial toxicity to patients. So it's good that these trials are being conducted.
Yeah. And there was also updates on the CROWN study. So the CROWN trial looks specifically at ALK mutant non-small cell lung cancer patients who are metastatic. And this study was already published, and we already have the approved drug called lorlatinib, which is a pill for these ALK fusion positive patients. But the update of the CROWN study actually provided a 5-year update. And they looked at lorlatinib in comparison to crizotinib in the first-line ALK fusion metastatic non-small cell lung cancer. And the progression-free survival at 5 years for crizotinib was the median progression-free survival for crizotinib was 9 months, comparison to lorlatinib, where at 5 years, 60% of patients were progression-free. So the median PFS was not even reached at 5 years for this drug, which we're talking again about metastatic non-small cell lung cancer. So that's a pretty impressive feat.
No, that's pretty remarkable. What just out of curiosity, I think we all get really excited in non-small cell lung cancer about the target therapies, just because those are, the success stories. What do all of you think about the future of non-driver mutated non-small cell lung cancer, and what could be the potential future there in terms of giving patients long-term efficacy benefit?
I'll answer that question, and then I want to comment on the CROWN findings that Dr. Vojnic just shared. I think in terms of future kind of treatment combinations, what's been really excited, and a lot of the data which were shared at the meeting involved new antibody drug conjugates. Perhaps Dr. Vojnic will review a couple of these studies shortly, but I think this is a really interesting treatment frontier and actually paradigm that's been adopted in other sorts of disease states. In thoracic oncology, we have an approval already for trastuzumab deruxtecan, but we hopefully will see some additional ones moving forward, which is quite exciting. I want to reiterate what she just shared about the PFS findings. I don't think it takes a patient with cancer or a provider treating cancer to understand that when you have curves that literally look like this on the screen, it's a very good thing for patients. And that's indeed what we saw in the CROWN study. It's easy to get excited about findings prematurely. I don't think that's the case in the study.
Fully agree with Dr. Kareff. Yeah, there was a lot of data on antibody drug conjugates. One of the trials that was presented was the EVOKE-01 trial, which looked at sacituzumab govitecan or Trodelvy versus Taxotere, so docetaxel in the recurrent non-small cell lung cancer setting. This was a phase 3 study. It did not meet its primary endpoint of OS benefit, but there was a numerical OS benefit, 11 months versus 9 months for the Trodelvy subgroup. In addition to that, there was also some data presented again about Dato-DXd, which is another antibody drug conjugate, where there was a benefit seen in Dato-DXd in comparison to Taxotere, especially in the non-squamous cell histology group, again, recurrent non-small cell lung cancer patients. So in summary, this antibody drug conjugate for the recurrent setting are definitely something that is an option, or hopefully will be an option in the future for these patients with non-targetable non-small cell lung cancer. It is though also still exciting that we're moving more also adding immunotherapy in the small cell lung cancer sphere, where we also had the study presented Beat small cell lung cancer, where they looked at newly diagnosed small cell lung cancer sphere and adding atezolizumab, so another immunotherapy drug, in combination with platinum-based etoposide therapy with bevacizumab. And the median PFS, where they looked at small cell lung cancer, was actually improved with adding bevacizumab, but the overall survival wasn't. So while progression-free survival data for some targetable therapies can be very exciting, in the non-targetable therapies, we're not always very sure that there's going to be an overall survival benefit for these patients.
Well said. So a lot of exciting stuff happening in the thoracic world. Nagashree, do you want to speak a little bit about what's been going on in head and neck, or anything that was particularly exciting at ASCO?
It's, like, it was not like long, let me say that, but there were some take-home points. I always feel like, this is, again, this tumor, and you can speak to other tumors as well. There are some, cancers that are not, as represented in meetings like this, and head and neck is one of them, sadly. But there was some silver lining to this cloud, and a lot of these studies, I would say, is kind of adapting from the lung cancer space. So I'll be speaking about a few things that you've already heard. Let me start off with oropharyngeal cancer, where a lot of research is currently being done, HPV-driven oropharyngeal cancer. So there's this study called E3311. It's a large cooperative group study, a phase 2 trial of transoral surgery followed by pathology-based adjuvant treatment. So currently what we're doing is patients with this disease either get the surgery and then follow with adjuvant treatment as appropriate based on their pathology, or they get treated with concurrent chemoradiation. There is this concept of de-escalation, which is not the best term, but anyway, trying to do less harm for patients while not compromising on efficacy. In this particular study, all patients underwent surgery, and based on what they found at the time of surgery, they were, the patients were cohorted into 3 groups, actually 4 groups. The first group is, low tumor stage, fewer lymph nodes. There was no, the capsule of the lymph node was not invaded. That's Arm A. Those patients were just observed without any they were just observed without any additional radiation. Then there was the Arm B, where patients were, had intermediate risk factors of fewer extra lymph nodes, and then there was a little bit of extra nodal extension, a little bit of capsular breach, if you will. And they were randomized to receive low dose radiation versus higher dose radiation. And then there was a last group where there was obvious high risk features, and those patients received full dose radiation. This is a long-term follow-up study, and essentially what they found was for all groups of patients, regardless of the type of lower treatment strategy that was adapted based on pathology, they all had wonderful outcomes. So suggesting that lowering the amount of radiation post-operatively may not compromise the overall outcomes. There was no real, they didn't delve deeper into toxicity, etc. But overall, this is promising because a lot of times we are debating whether patients should get full dose radiation. I mean, there are many other studies that are going on in this space, but I think this was very reassuring. The next study I wanted to highlight was, who are the patients that we detect who these patients are who are at higher risk for recurrence, other than looking at pathology. And one of the things that has been looked at in many other types of cancers is circulating tumor DNA. In this particular space, in the HPV cohort, there is development. Several companies are working on this. There is the circulating tumor HPV specific DNA, looking at the levels post-surgery to look at minimal residual disease, meaning if it is detectable after surgery in peripheral blood versus those that did not have any detectable CT HPV DNA post-surgery that compared, and it was an astounding 0 to, it's a 2 years of progression-free survival was 0 to 97%. So if they had positive ctDNA post-surgery, the progression-free survival at 2 years was 0%, whereas if they didn't have it, then it was 97%. So that's a huge number, which I think is quite impressive. Having said that, I think the next one that I wanted to talk about was, what about patients who have undergone surgery? Is there anything that we can do better? Not only in the oropharyngeal space, but also in other, subsites of head and neck cancer. So, of course, we've been talking about adjuvant immunotherapy in lung cancer. We heard that quite a bit just now, but in this particular case, it was a phase 2 study called the Pathway study, looking at pembrolizumab compared to placebo in patients with head and neck cancer with high risk for recurrence. And how did they define high risk of recurrence? They had six different risk groups. And again, they're all previously sorted out. These are patients who had high disease burden or required salvage surgery after chemoradiation, or they had some suspected maybe external metastases at the time of diagnosis, or had oligometastasis. I mean, there were a few subgroups of patients that they selected for the study. And after they completed concurrent chemoradiation, which is the standard of care for these patients, they went on to receive pembrolizumab versus placebo. The progression-free survival at 2 years was significant, 65% compared to 54%. And the overall survival was not different between the two groups, but the progression-free survival was quite impressive. The response rates were also increased in the ones that received the pembrolizumab. So again, this is something that is kind of taking information from another disease and adapting it into the head and neck space where we really don't have much. So what about neoadjuvant therapy? We spoke about that quite a bit in the lung cancer space. So what about neoadjuvant? There was this study, was a phase 2 study looking at sintilimab, which is a PD-1 inhibitor with platinum doublet chemotherapy, followed by transoral robotic surgery for HPV-associated resectable oropharyngeal cancer. It was a small study, but why I'm mentioning this is because there was 100% response rate. So the patients who received 2 cycles, there was 100% response rate, out of which 52% was confirmed to be a pathological complete response. So these numbers are pretty impressive. And of course, it's a very early study, from, all patients were from China, but it will be interesting to see what it looks like, when the study gets to the next phase. What else? So what about, patients with metastatic disease? Now we spoke about patients with contained disease. What about those with metastatic disease? A lot of studies looked at vaccines. There was some renewed interest in vaccines. Along with immunotherapy, there was a peptide vaccine called IS-101B. It was a phase 2 study of this vaccine combined with immunotherapy, semipilimab in this case. Vaccine was given at 3 different time points. There were 198 patients who were enrolled in the study. The overall responses were not, that different. However, when they looked at patients who had a tumor, PD-L1 positive tumor composite CPS, as we call it, proportionate score of 20% or higher, meaning higher PD-L1 patients had a significantly better outcome. The toxicity was similar in both arms. So another vaccine study also looked at, this was a viral-based vaccine study, also looked at similar endpoints and showed the same type of results. So again, PD-L1 seems to be a deciding factor as to whether these vaccines work or not, at least based on the 2 studies that were presented. Lastly, I wanted to talk about nasopharyngeal cancer. There was a couple of really nice papers, nice presentations about this. One of them is called the DIPPER study, looking at, again, adjuvant pembrolizumab, which is a PD-1 inhibitor approved in China for a variety of different types of cancers, after patients received the treatment that is appropriate for a condition called nasopharyngeal carcinoma, which is usually driven by a virus called Epstein-Barr virus. They saw that patients who received all treatments that they needed, chemotherapy followed by concurrent chemoradiation, and then they were randomized to receive the immunotherapy versus observation. They saw that the event-free survival, was 86.9% versus 77.4% for the placebo. The side effects were also slightly increased. There's one unique side effect with this drug called reactive capillary endothelial proliferation, which is really just bumps on the surface of the skin, which contains blood vessels that can bleed, which is something very specific for this molecule. That was seen, that was the #1 side effect that was observed. Similar studies, again, just like in oropharyngeal cancer, looking at introducing immunotherapy early on with induction, and then continuing beyond concurrent chemoradiation. There was another study, it was a phase 3 study, also showing that perioperative immunotherapy can yield improvement in responses and progression-free survival. So that's what I wanted to say. There are many other ones that deserve some attention, but we don't have much time here, so I'll just stop.
Oh, no, thank you so much. And it looks like we have a question. This is from Tatiana Davidoff. Is there any interest in metabolic therapy consisting of a ketogenic diet combined with glutamine blocking drugs such as DON or M-bendazole, exercise, and low-dose chemotherapy?
None. It was, to my knowledge, something like this was not presented at ASCO. Are we talking about just at ASCO or in general, or is it?
I think the question is about general interest in that field and potential. Yeah,
there's plenty of data supporting exercise in patients going through cancer treatments. The question about diet is somewhat, again, there's no great randomized studies as far as I know, and I do not know what the low dose chemo means, but I think they were all being used before as immunomodulators. Again, we have better agents now to kind of do that, so we kind of moved away from that. But perhaps that's the question, right?
And there's several clinical trials right now ongoing where they're looking at ketogenic diets specifically for brain tumor patients, even if ketogenic diets improve outcome. There is some preclinical data, like in many other cancer types, but specifically for glioblastoma, there is some encouraging early data, and now larger trials are ongoing. And I think at ASCO they did present a planned study, but no results yet. So we don't know yet.
I saw the planned study, but it was more of a clinical trial in progress type of.
Yes, correct.
Yeah.
No, yeah, absolutely a really great topic. And I think we are now starting to think about, more than just systemic therapies, but how things like ketogenic diets may alter the tumor microenvironment and augment the therapies we already have. So it's a great question. Another question is, were you encouraged by the results presented about multi-cancer early detection platforms?
I'll yield this one to start. I think my quick response to this is cautiously optimistic. And I say that trying not to get into a lot of these stories that are in the news right now, but keeping it very patient focused. I think that we all, patients with cancer, providers treating cancer, industry trying to get over these diseases as well, want to see blood tests that are able to detect cancer as early as possible. But I think we need to be very careful about how those are employed in clinical practice. Obviously, false positives lead to a lot of downstream sequelae, like increased healthcare costs, a lot of anxiety, over testing, et cetera. But when done correctly, and this is why I'm cautiously optimistic, I think there's a great frontier here. So we'll see where things go in the next few years.
Yeah, I couldn't agree more with that. I think, broadly speaking, the concept of detecting cancer before it's metastatic is something that we should all strive for. And I think, finding cancer before we have to treat cancer is ultimately the goal. But I think we've all had experiences personally in both, in learning statistics that, false positives and false negatives exist, and also, finding things that may or may not end up being cancerous in the future, leading to unnecessary tests and unnecessary morbidity and mortality for patients in these types of situations. There's a lot of things that we're going to have to figure out over the next, I would guess, in my humble opinion, I think, we're very many years away from a test like that. And I think we have to go about it the right way.
There's a lot. It's it's a learning curve for these systems to kind of identify. And I think at this time, they're still in a data collection mode. I wouldn't be able to rely on any of that and act on it. There are situations where we use it, and just for as a screening test, I think it's more anxiety than actually helpful, at least unless you're enrolled in a clinical trial involving these tests.
Couldn't agree more. Well, I know we're kind of getting a little bit low on time, so I'm just going to finish by talking about some of the highlights in melanoma. I think melanoma obviously had a plenary session this year, the Nadina trial, and to be honest, this is both relevant to every tumor type in oncology, given the platform that was studied, but particularly impactful in melanoma and adjuvant and neoadjuvant management of melanoma specifically. So this was a phase 3 study in which patients were randomized in a 1-to-1 fashion to receive either adjuvant nivolumab alone, which is standard of care, or 2 doses of neoadjuvant ipilimumab and nivolumab. And then if they achieved anything less than if they had a non-response or only a partial response, then they went on to get.
But otherwise, they were done with two doses. And the primary endpoint for the study was event-free survival at 12 months. And the neoadjuvant arm showed an event-free survival of 89.7% versus 57.2% in the adjuvant-only arm. And interestingly, the toxicities in the neoadjuvant-only arm included anything grade 3 or higher of 29.7%, with it being about 10% lower in the adjuvant-only arm. So really, really important data, potentially practice changing for a lot of people. I've heard a lot of polarizing opinions about this. There's a lot of people who say that the benefit of, the event-free survival hasn't been borne out with overall survival yet. So we don't know what to make of this data, even though it's quite impressive with the landmark analysis at 1 year. But I hear a lot of people concerned about toxicities and whether or not you're actually getting a better risk-benefit balance by giving neoadjuvant therapy versus just adjuvant, where you have a lower toxicity risk. But this is where we're going in oncology in general. I think, the concept that you give immunotherapies while a tumor is still in place and you have both the neoantigens in place and tumor infiltrating lymphocytes is makes a lot of mechanistic sense. And there's a lot of basic science to back that up. But, we are still very much in the infancy of trying to figure out who's going to get toxicities, who's going to, grade 3 toxicity is one thing to talk about, but as we've all experienced, as we start to give more checkpoint inhibitors, there is the 1% of patients that get myocarditis, or there's the 1% of patients that get, type 1 diabetes, and how do we manage these very significant potential side effects in counsel patients? So it's a very interesting trial. I'd be curious to hear what other people's thoughts are on it, because it's certainly something that's really being discussed a lot about in the melanoma community.
Yeah, Dr. Hadfield, I'm glad you brought this 4th of 5 plenary sessions up today. And I know one of your research interests is identifying patients at risk for toxicity from immunotherapy. Obviously, a very important point for the field to identify, especially for patients receiving these novel sort of therapies, even though we have almost a decade of routine use of them at this time. I think what's so exciting about this plenary session specifically is talking about neoadjuvant, meaning before surgery, immunotherapy alone. I'm really struggling to think of examples, and I don't even think phase 3 data has yet been presented, but outside of cases like colorectal cancers with mismatch repair deficiency or microsatellite high instability, where neoadjuvant immunotherapy alone has led to improved outcomes. So if I were a patient listening to this podcast, I'd be excited, because I think that this might change the treatment paradigm in a lot of other disease states besides melanoma, which you just shared with us today.
No, yeah, absolutely. And I think, from a patient perspective, I think one of the big things to keep in mind as we start to use these therapies more in the earlier settings, specifically neoadjuvant, adjuvant settings, when we get into curable diseases, is and in melanoma high risk stage 2, we're giving adjuvant immunotherapy now. There really is a misnomer in calling these therapies chemo sparing. That they're really not. They have their own type of toxicities and their own risks. So I think it's really important to feel comfortable that you understand that as you make these big decisions about what you'd like to do in terms of treatment perioperatively. But I think that pretty much wraps up our conversation. I'm not sure if we have any other questions or if anyone has any other comments before we say goodbye.
No, it looks like that's about it for questions. So thank you to everybody who asked those questions, and thank you for the great answers. So awesome. This is a really wonderful summary of all these updates that were presented at ASCO. It's definitely inspiring to hear about all this new research that's coming into the field. And thank you to the audience for tuning in today. If anybody has any remaining questions after the live stream concludes, you can still type them into the chat on the YouTube video and we can answer those offline. So thanks again to everybody for participating, and hope you have a great rest of the day.
Awesome. Thank you.